Salawat. Now we'd like to start the main program with recitation of Quran. So let's welcome Ammar with Salawat ala Muhammad wa ala Muhammad. Allah. Salli ala. Yes.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. ولقد آتينا لقمان الحكمة أن اشكر لله ومن يشكر فإنما يشكر لنفسه ومن كفر فإن الله غني حميد. وإذ قال لقمان لابنه وهو يعظه يا بني لا تشرك بالله إن الشرك لظلم عظيم. ووصينا الإنسان بوالديه حملته أمه وحنا على وحن وفصاله في عامين أن اشكر لي ولوالديك إلي المصير. وإن جاهداك على أن تشرك بي ما ليس لك به علم فلا تطعهما وصاحبهما في الدنيا معروفا واتبع سبيل من أناب إلي ثم إلي مرجعكم فأنبئكم بما كنتم تعملون. يا بني إنها إن تك مثقال حبة من خردل فتكن في صخرة أو في السماوات أو في الأرض يأت بها الله إن الله لطيف خبير. يا بني أقم الصلاة وأمر بالمعروف وانه عن المنكر واصبر على ما أصابك إن ذلك من عزم الأمور. ولا تصعر خدك للناس ولا تمش في الأرض مرحا إن الله لا يحب كل مختال فخور. واقصد في مشيك واغضض من صوتك إن أنكر الأصوات لصوت الحمير. صدق الله العلي العظيم.
Today we're very fortunate to have Dr. Raghib Ali, who will be speaking to us on a talk entitled COVID-19 and New Insights into the Health of British Muslims. Let's welcome him. Salat ala Muhammad wa ala Muhammad. Dr. Raghib Ali is an honorary consultant in acute medicine at the Oxford University Hospital NHS Trust, and he's the associate professor at New York University, Abu Dhabi. He graduated from Cambridge in 2000 and has been awarded postgraduate studies in epidemiology and Public Health from the Universities of London, Cambridge and Oxford. He's also the principal investigator for the UAE Health Future Study, investigating risk factors for diabetes and cardiovascular disease, and an independent expert advisor to the government's Race Disparity Unit on COVID and ethnicity. Salawat ala Muhammad wa ala Muhammad.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Alhamdulillahi Rabbil Alameen. As-salatu was-salam ala Rasulullah. Thank you very much, Mikhdad. So one thing Mikhdad didn't mention is that we knew each other from our days at Oxford many years ago, and very pleased to meet him after quite a long time and to be invited to speak to you this evening. We have a very wide range of ages in the audience. So, which is nice to see. I will try to keep it as simple as possible so everyone can understand, inshallah. Actually, recently I gave a talk at a school on COVID, and it's the first. I'm used to giving talks to mainly doctors and health professionals and sometimes journalists, but this was the first time I'd been asked to give a talk at a school on COVID, and I got asked probably the hardest question I've been asked by anyone, which was that if COVID was a person, what would you say to it? And so sometimes kids ask very important questions and difficult questions. So if our youngsters today have any questions at the end, I'll be happy to take them. So the title I've mentioned there is half the talk is really about COVID-19 and what we've learned about COVID in relation to its impact and its disproportionate impact on British Muslims, British ethnic minorities, and also some data that as a result of this disproportionate impact, more work has been done by various government agencies and various researchers on the health, other aspects of health as well, other diseases, other causes of death and disability. This topic, it's not something I planned when I first kind of came out. As Mikhdad mentioned, I've been working in Abu Dhabi for quite a few years, and I returned kind of to the UK in March 2020 when the COVID pandemic struck, and I still had my license to practice as a clinician at the hospital in Oxford. I hadn't practiced for a while, but I knew that it was going to be a difficult time, and I thought I should volunteer to go back. And so alhamdulillah, I was able to help out for particularly in the first wave, but all the subsequent waves as well. And I saw firsthand, both through my clinical practice and sadly through the deaths of colleagues as well, the impact that COVID had in my family as well, particularly in India with the terrible wave in 2021. Many people died, of course, including relatives. I know that many people in the audience, whether here in the hall or at home, would have had similar experiences. And I really wanted to start by reflecting on that. It's been a very difficult time. I lost my father as well just over a year ago, not to COVID, but indirectly. He was, because of partly of his age and also his lung condition, he was very scared of going to hospital, and there may have been an indirect impact there. But of course, we are content with the decree of Allah, and we ask Allah to have mercy on all those who have died and give patience to their families. But I wanted to mention that at the beginning because I know this is an issue which has had an impact on almost every family. Okay, these are a couple of headlines from the first and second wave, where it became clear not just to people working in hospitals, but also to the wider kind of community, that COVID was having a disproportionate impact. Particularly in the first wave, actually, it was mainly particularly on black communities, black African, black Caribbean. In the second wave, it was more South Asian communities. But early on, the Office for National Statistics did some research which also looked at religious affiliation. So in the first wave, it showed that both Muslims and Jews had higher death rates, and in the second wave, it was more apparent in Muslims. And I'll show you some of that data. So I'm afraid it's not entirely clear, but you can see there's two bars there, one in blue for males and one in green for females. The one which is going furthest to the right is the Muslim view there for males in particular, but you can see for both males and females, and this is this is from the period until the 28th of February 2021, which was the last set of data we have. which did show that there was a higher death rate amongst Muslims compared to every other religious group. And I'm going to talk a bit more about that. But most of the data we have, is not based on religion. I mean, the ONS does collect data on religion, as we know, at the census, but it's not a compulsory question, whereas ethnicity is a compulsory question. So you have to say what your ethnic group is. So most of my talk is going to be about ethnic groups, and I'll reflect back on that to Muslim groups as well. So what I'm going to talk about now, I'm afraid, is probably going to be over the heads of the kids, and but it is epidemiology. So as I am an epidemiologist, so I'm going to talk about risk factors and what causes disease, and in this case, we're talking about COVID. So what we were interested, so I guess I was in a slightly unusual position, and I'm not the only one, but there's very few of us who are both kind of clinicians dealing with COVID and epidemiologists looking at COVID data. And so I was naturally interested in looking at the data to try to find out and to try to explain what was causing this disproportionate impact. So I've divided it up there into two kind of broad categories. So there's two main reasons why you'd have an increased risk of death in a particular population group. Either you have an increased risk of infection, and there are a number of risk factors mentioned there. So obviously for an infectious disease, the number of contacts you have, how likely those contacts are to be infected, and how close you are in terms of your interaction with people will determine how likely you are to be infected. And there's other things which affect that. So how densely populated the area is. So London, as you know, you live in London, has the highest kind of population density in the UK, and as we'll see later on, it had the highest rates of COVID deaths as well. Household size, of course, is extremely important. Most COVID transmission, the biggest proportion of COVID transmission takes place in the house. So it's a bigger risk factor than, for example, occupational exposure. And in our communities, as we know, multi-generational households are much more common, and I'll come back to that. Occupation is important if you work in healthcare, as I do and some others in the audience, or in other occupations where you come into contact with the members of the public on a daily basis, then you're more likely to be infected. Deprivation is an indirect, so it's not that deprivation by itself causes you to be more likely to be infected, but if you're generally deprived, you're more likely to work in occupations or live in bigger size households or live in more densely populated areas. So it's a kind of proxy for that. And similarly with ethnicity, some ethnic groups, not all, but some ethnic groups are more likely to have those characteristics as well. And then the second thing is, once you're infected, what affects the outcome? By far the biggest risk factor for death from COVID is age. I mean, it's a very strong relationship. So pretty much for every 10 years of age, your risk of death doubles. And I think people in their 80s have 10,000 times the risk of death of an 8-year-old, for example. So it's a huge increased risk. Males, for various reasons, have a higher risk of death than females. That's common for lots of diseases. For infectious diseases, there's various theories as to why that is, but it seems that females have a better immune response, and that protects them from COVID, although there's still work going on there. What I've described there as comorbidities basically means other diseases that you have, so obesity, diabetes, hypertension, etc. How you're treated in hospital could have an impact, of course. It's not such a big issue in the UK where everyone has free access to healthcare, but in America, for example, you don't have health insurance, you can't get access often. In poorer countries, of course, you can't get access if you can't afford it. In developing countries, genetic factors could be important. Ethnicity, again, is a kind of proxy for some of these other factors. The final point there I will skip for now because it's somewhat speculative. So on the first point about infection, so we have got data from, not really in the first wave because people were not being tested at that time, but we can see how, this is second and third wave data, where they did publish, the Office for National Statistics again did publish some data on infection rates. And you can see that in the second wave, which is the kind of first peak that you can see there, Muslims had a significantly higher rate, for example, than Christians, Jews, similar to Sikhs and Hindus. And then in the second wave, the pattern was in the third wave, the pattern was different, and I'll come back to that. But this is really to illustrate that we have got some data by religion, but not much. What we mainly have is religion by ethnicity. And so most of what I'm going to talk about is what we find for Pakistanis and Bangladeshis. So in the UK, this is the breakdown of the Muslim population from the 2011 census. It would have changed, of course, somewhat since then, and we'll get data this year on this. from the 2021 census. But you can see that the majority of Muslims in the UK are of South Asian origin. The biggest by far is Pakistani and then Bangladeshi. And nearly all Pakistanis and Bangladeshis are Muslim. I can't remember the exact figures, but above 95%. So I'm going to focus on the Pakistani and Bangladeshi group. For the Black African group, of course, that proportion has increased, or the numbers have increased, but it's only about 15% of the black group are Muslim. So I'm going to focus on Pakistanis and Bangladeshis. Okay, this slide is a little bit difficult to explain actually to a non-specialist audience. I'm just going to mention a couple of key points. If you just focus on maybe on the top row, which is Bangladeshis, and the left-hand side is showing women, and the right-hand side is showing men. And then further down, you'll see there are basically two groups there's more than two, but in the second wave, let me point to the screen for a moment. I just want to focus on this side, on the right-hand side. So it shows fairly early on that Bangladeshis and Pakistanis in the second wave had an increased risk compared to the first wave. And if you compare the rates for deaths for Black African and Black Caribbean, that pattern was changed in the second wave, and I'll come back to the reasons for that. But this slide is really just to show that things did change between the first and second waves. And they changed again in the third wave, but it's too much to show on one slide. This is trying to explain what's caused the increased risk. So this is all data from the Office of National Statistics. So what this is trying to show, if you just focus on the top line, which is the Bangladeshi group. So it shows that for Bangladeshi men, without adjusting, so we do something in epidemiology called adjusting for risk factors to try to explain what's causing the increased risk of an outcome, in this case death from COVID. So if you just focus on the very top bar, which is in light blue, that's the risk without adjusting for anything. So men, this is in the second wave, had a 5 times higher risk of death from COVID-19 compared to whites. And Pakistani men had a more than 3 times risk. For women, Bangladeshis had a 4 times risk, and for Pakistani women, just under 3 times risk. It's without adjusting for anything. So that number is the one you should remember in terms of what the disproportionate impact was. So a very large and huge impact, really, disproportionate impact. And this is adjusted for age. Pakistanis and Bangladeshis are much younger on average than the white community. If you don't adjust for age, then actually the white community had similar death rates because they're much older. But in epidemiology, we usually adjust for age, particularly in a disease which is very much determined by age. So what the adjustments are doing is to try to explain what's caused that increased risk. And if the first one is to do with living in care homes. So if you lived in a care home, that was very bad in relation to COVID mortality. But very few Pakistanis and Bangladeshis or Muslims live in care homes. So that actually had the opposite impact. So if you adjust for care home, that's why it goes in the opposite direction. So whites are more affected by that. But it's the others that I want to focus on. So if you adjust for where people live, so most Pakistanis and Bangladeshis or most Muslims live in urban areas, conurbations, as we know, predominantly in London, also Birmingham, Manchester, Yorkshire. So they're very heavily concentrated in a few areas. So adjusting for where people live explains some of the risk. If you adjust for things like, as I mentioned, household size, deprivation, that reduce the risk or explain some of the risk further. If you adjust for comorbidities that I mentioned earlier, whether people have diabetes, and for example, Pakistanis and Bangladeshis have higher rates of diabetes than white English, then again that explains some of the risk. Even after you adjust for all of those things, you'll see on the grey bar, looking again at Bangladeshis, even after adjusting for all of those things, there's still roughly double the risk for men and just under double the risk for women, and same for Pakistani men and slightly less for Pakistani women. Whereas for the other ethnic groups, once you adjust for most of these risk factors, the excess risk is explained by that. So Pakistanis and Bangladeshis and Indians to an extent still have an excess risk even after adjusting for those. I should say, if you want to stop me at any point to ask questions, it's fine, because this is, for those of you who are not epidemiologists or doctors, you might struggle to follow everything. Okay, this is, again, you don't have to focus too much on the details of the slide, but this is just showing that the peaks that you see on the left-hand side show that the highest rates of death were in London. So living in London for COVID, or living in London was bad for COVID mortality. On the right-hand side, it just shows that if you lived in a densely populated urban area, you had roughly 5 times the risk if you lived in a very rural area. And that's kind of obvious for an infectious disease. You're less likely to interact with people and have contacts. So that's kind of hopefully easy to understand that geography would have that impact. I mentioned this earlier. This just gives the figures that a significant majority of all ethnic minorities live in major urban conurbations, a much higher rate than whites. Deprivation is slightly more complicated. There is still a strong relationship between living in a more deprived area and mortality from COVID, as I described earlier. But in the third wave, it wasn't as apparent, and I'll come back to that. But yeah, in general, it's true to say that deprivation gives worse outcomes, not just from COVID, but all causes of death. In the UK, there's a very strong what we call deprivation gradient. So the more deprived or the poorer you are, the worse your outcomes from pretty much every disease. Again, without going into detail of this slide, it basically shows that Pakistanis and Bangladeshis are the most deprived groups in the UK. If you look at the areas, this is based on postcode where you live. So it doesn't necessarily mean individuals, although there's obviously a link between that. But it's not as strong, actually, for Pakistanis in particular. So Pakistanis are quite likely, or more likely, for example, than many other groups to own their own home, but they tend to live in more deprived areas. Occupation was extremely important in the first wave. So healthcare workers, as I mentioned right at the beginning, were disproportionately affected as well. And Black African and Black Caribbeans are more likely to work in healthcare. Pakistanis and Bangladeshis actually are not. But if you look at and this was obviously well publicized at the time, if you look at not just the ethnicity, but the religious background of many of the doctors who died in the first wave, it was obvious that the majority were both of South Asian or of Muslim kind of background. And that's not fully explained. I mean, one of the things I've done in my role as a government advisor is to ask them to investigate this properly. I mean, there are some studies going on to try to explain this, but I feel more resources need to go to try to explain, that disproportionate impact on healthcare workers. But it's likely that the disproportionate impact in black communities was because of their being much more likely to be healthcare workers. There were other occupations which were very badly affected. And again, without looking at every line of this, I'll just mention a couple. So taxi drivers. So 1 in 5 Pakistani men is a taxi driver. They're much more likely to be taxi drivers than other ethnic groups. Bangladeshis are more likely to work in retail, for example, and both groups are more likely to work in security. And security guards also have a lot of interaction with the public, of course. So any public-facing roles had higher death rates from COVID. Now, this slide in some ways is a key one to understand the disproportionate impact, particularly on Muslims and Pakistanis and Bangladeshis. So what it's showing is the relative risk of infection, or the relative rate of infection by age group and by ethnic group. So it's a slightly complex slide, but if you divide age groups into 3 there, you can see that there is a higher risk in Pakistanis and Bangladeshis to an extent in the younger age groups, but it's not a huge increased risk. It's about 1.5 to twice as high. In the working age groups, 20 to 64, again, there is a gradient. So it's about double the risk in Pakistan and Bangladeshis. But it's in the 65 plus age group where the vast majority of deaths have occurred overall that you see the biggest differences in infection rates. So Pakistanis and Bangladeshis have more than 3 times as high risk. So this is the key slide to understand that what's driven the excess risk in Muslims, Pakistan and Bangladesh is primarily risk of infection in older age groups. So that's data that was relatively recently published, but it's been subsequently shown in a more recent report as well from the Office for National Statistics. And this links back to a point I made about multi-generational households. So, I mean, this is a good thing that, alhamdulillah, in our communities, we do look after our elders. We don't, it's very rare in our communities generally for elderly, whether male or female, to be living on their own. So in the Bangladeshi community, you can see there that a relatively smaller proportion have people living, this is not just on their own actually, even as a couple, it's 27%, whereas 56% live in a multi-generational household of Bangladeshis and 35% of Pakistani. So roughly half, if you took both groups together, or somewhere between 40% and half of Muslims are living in multinational households. For whites, it's 2%. So a huge difference. It's a 20-fold gradient there. And living in a multinational household for an infectious disease obviously has significant risks, but for non-infectious diseases, it's actually quite good for your health. You don't have the, as I'll show you later on, we have lower rates of dementia, lower rates of a number of diseases, part of which is likely to be because we have those extended family structures and social networks. And coming to the mosque, for example, is also, another way that many elderly people interact with their communities, much more so than other communities. This gradient you see for multinational households almost exactly matches actually the mortality rate. So Bangladeshis, Pakistanis, Indians, and then Black Arab, if you look at the course of the whole pandemic. Okay, so this slide, without looking at the detail of the numbers, what it basically shows is that if you are over 65 years old and live with children of primary and secondary school age, you had more than 2.5 times the risk of death. So that kind of multinational household in the second wave. In the first wave, it wasn't as apparent, and although it seems like a long time ago now, in the first wave, schools were closed for most of this first wave, whereas in the second wave, the schools were open. And obviously that had an impact on children, particularly bringing back the infection into households. Again, without looking at the numbers, Pakistanis and Bangladeshis have higher household sizes than other ethnic groups. And every extra person in the house is a potential, source of infection. So that's just, and there's good reasons for that. We have more children as well, on average, than other ethnic groups, as well as I said, the living with our parents. This slide is an interesting one. So there was a study done which showed, or which measured how much people were mixing based on mobile phone use. So if you ask people, how much did you visit another household during lockdowns, most people say they didn't, which is, kind of expected. But what one study did, they actually looked at people's mobile phones, because on the mobile phones, there's a GPS tracker. So, and people agreed to this, more than 2 million people agreed to have this done. And so what they showed is that it wasn't quite as rare as the surveys showed. And in London, what was particularly interesting, and we're obviously in part of Greater London now, is that household mixing overall during the pandemic was actually slightly higher than before the pandemic. And during the lockdowns was also higher in London than other areas. And this is not just, it's partly in the second and third waves, as you may recall, there was a concept of household bubbles as well. And in our communities, sometimes we define households slightly differently as well. So I know in Bradford, I heard from one doctor there that they said when they said there's no mixing outside the household, they define the household as the wider family, not the house itself. So we've got fairly good data now to show that there was significant household mixing going on during lockdowns as well as outside of them. And it doesn't mean that Pakistanis and Bangladeshis are less compliant with rules, or almost less compliant. It's just that the type of non-compliance maybe is different. So, and it's in some ways no one should break the law, of course, but if you have elderly relatives or families who need someone to visit them, these things need to be weighed up, against the harms or potential harms. So anyway, that's and this doesn't break it down by ethnic group either, but London, as we know, is the most ethnically diverse part of the country. Well, also, in some ways, it's surprising that we didn't know this, or we didn't realize it at the beginning of the pandemic. Otherwise, we might have prepared slightly differently and given different advice. But this pattern of increased risk of death from other infectious respiratory infections, including influenza, which we've got the most data for, actually was there before. So even in 2015, a paper was published looking at swine flu, which most of you will remember, which again was at one point was thought that was the last pandemic we had. Fortunately, it didn't cause significant numbers of deaths. But there were higher death rates in Pakistanis and Bangladeshis even in that. Seasonal influenza, again, the highest rates in South Asians, and again, pneumonia, the highest rates in Pakistanis and Bangladeshis. So for respiratory infections in general, this pattern is now well established. And again, for all the reasons we mentioned, or I mentioned. The final part of this on COVID is to do with this on one of the slides I showed at the beginning, I said that even after adjusting for all these risk factors, there was a residual, what we call a residual risk. There was still roughly a double risk of death in South Asians in particular. And this was a bit of a mystery for a long time, and it's still not fully explained. We've got a better idea now. And this basically means that if you get COVID, you have a worse survival once infected. And that's particular to South Asians. And it might explain to an extent what happened in India as well. So we have data from the UK as well as the US and other countries, which shows that it's only really South Asians that have this high or worse survival after being infected. So for blacks, that's not true. So their higher risk was mainly just through higher risk of infection, whereas for South Asians, there was this worse survival as well. I'm going to skip that one. It's a bit difficult to explain. But okay, I'll just mention one point on this. On the right-hand side here, it shows that actually for people that were admitted to intensive care, the black group had better survival than the white and South Asian groups. And again, that was somewhat unexpected. But what we've found since then is that there is a genetic risk factor, and you may have seen this in the news a few months ago. There's been a few more papers published since then which show that there is a genetic, and it's not that surprising. For most diseases, in fact, for pretty much every disease, it's a combination of genetic susceptibility and environmental risk factors, even for things like lung cancer. I mean, smoking is a very strong risk factor for that, and generally smokers don't get lung cancer, but there is a genetic susceptibility even for something like lung cancer. For COVID, we've found that there are some genetic or some genes that give or mutate a particular kind of version of a gene, which confers a higher risk of death from COVID. So it roughly doubles the risk of COVID. And in younger age groups, and again, because South Asians tend to be younger, it would have a disproportionate impact, and that risk is even higher. So nearly 3 times risk of death or severe COVID. And what you can see at the bottom there is that South Asians are more likely to have that genetic risk factor. So, and that, as I said, it might explain why we've had higher death rates in India particularly. And a paper actually just published today suggests that Pakistan and Bangladesh also had significantly higher risk, higher death rates from COVID. It's very rare in East Asians and very rare in Africans. And if you look globally again, East Asia and Africa have had lower death rates, so sub-Saharan Africa. Europe, we haven't got data for the Middle East, but the Middle East tends to be, if you look at their genetics, they tend to be a combination of European, South Asian, as well as their own local kind of mutations. So this is what most likely explains that worse survival and residual risk. And if you take this into account, that explains why, as well as all the other risk factors I've mentioned, why we have had higher death rates from COVID. Okay. Final couple of slides is just showing, I said that nearly everything is based on Pakistanis and Bangladeshis, but the Office of Nationals have done the same thing recently. This was just published a month ago. For Muslims as well, and it shows basically the same pattern, that there is this increased risk, roughly 2 to 3 times, and once you adjust for various risk factors, it decreases, but there's still some risk there. And for other religious groups as well. So you can see that in the first and second wave, so the left-hand side is the first wave, the right-hand side is the second wave. Not huge changes, to be honest, for Muslims, but there were for some other risk for some other religious groups. In the third wave, things were slightly different. So I mentioned earlier that infection rates actually were slightly lower in the third wave for South Asians and blacks and Muslims compared to whites or Christians. And this is really due to differences now in vaccination rates. So once vaccination came in, then one of the biggest risk factors for both hospital admission and death from COVID become rates of vaccination. And unfortunately, we've had lower rates for various reasons, and some of them are very valid reasons why there's less trust and decreased uptake. And one of my roles was to try to help with that. And we made some progress, particularly in the Bangladeshi community, where rates went up significantly in vaccination rates. And it did across all ethnic groups, but slightly less amongst Pakistanis and amongst Muslims. And if you look at the vaccination rates, so on the left-hand side, it shows the ethnic kind of breakdown. So Pakistanis, you can see there, only about 30-something% had the third dose compared to nearly 70% of white British. Bangladeshi is somewhat better. On the right-hand side, you can see the religious breakdown. So roughly 40% of Muslims versus nearly 7% of Jewish and other ethnic groups. So that, this is something which I think we need to continue to work on and to build that trust and to encourage people to take the vaccine, because it's made a huge difference overall to death rates. Okay, so that's the first half of my talk, which is about COVID. Now, the second half is, as I said, because COVID had this disproportionate impact, a lot of research has now been done to look at what was happening pre-COVID, and hopefully going forward there'll be more data on what happened post-COVID as well. But most of what I'm going to present now is based on data pre-COVID, because obviously we're not in the post-COVID phase yet. So when this disproportionate impact became apparent, a number of government reports were done, a number of things were published, which I've just mentioned a couple of the quotes there, which the widespread view was that COVID-19 was just another example of how ethnic minorities do worse in health outcomes, whether South Asians or blacks. And you can see there the final quote, which was in the BMJ. There's on almost all health measures, ethnic minority groups, especially black and South Asian people, have the worst outcomes. The COVID-19 pandemic is just another example. So I knew from my previous, one thing I didn't mention at the beginning, so why did I get involved in this work in the first place? Partly because I said I worked with COVID patients, but it's in relation to ethnicity, it's because I had done quite a lot of work on the outcomes for cancer, so cancer incidence by ethnic group when I was at Oxford, and we published a few papers on that, the first kind of national breakdown of how cancer incidence varies by ethnic group. And I knew from that work that, for example, Pakistanis and Bangladeshis, but particularly Pakistanis, the work we've done had significantly lower rates of a number of cancers. So esophageal cancer, colorectal cancer, pancreatic cancer, and I'll show you some of the data, but for lots of cancers, they had lower rates. So I knew this wasn't correct, and that's one of the reasons I got involved in looking at the data again, although my research has moved on since then. As I mentioned, I've been mainly working in the Middle East, because I was interested in what was causing disproportionate rates of diabetes there. But coming back to the UK data, so these are some statistics which have been fairly well publicised. Of course, the first one I didn't talk about intensive care, but this was fairly well known that we were more likely to be intensive care. The pregnancy data on black women being 4 times having a higher death rate, Asians doubled, diabetes, Bangladeshis having the highest rates of diabetes. In relation to mental health, significantly higher rates for black Caribbean men of having psychosis, which is a kind of severe mental illness, and more likely to be detained under the Mental Health Act. And if you look at self-rated quality of health, again, it tends to be lower, particularly for Pakistani and Bangladeshi women and Indian women, and to an extent for men as well. So these are all kind of important statistics and outcomes, but as I said, they're a selective kind of picture, because there are other statistics you can look at which show something different. So, for example, as I showed earlier, COVID-19, blacks had the best survival in intensive care. South Asians, once diagnosed with these diseases, had better survival than whites, for example, diabetes, cardiovascular or renal disease. I mentioned some of these things for cancer. So Bangladeshi is having 1/3 of the risk of breast cancer. Pakistan is 1/5 the risk of esophageal cancer, much lower risk of multiple sclerosis. So what I think is important, this is now speaking more as a epidemiologist, is that we look at the totality of the evidence. We don't kind of cherry pick select statistics to look at what the health outcomes are. We didn't have a very comprehensive picture for lots of outcomes until recently. It's only really been in the last 18 months that we've got much better data. So one of the surprises, at least to me, and most people who work in this area, was that pre-COVID, so Public Health England, when they published their first report showing mortality or death rates, from COVID, they also compared it to what had been happening pre-COVID. And again, I mean, the graph there, the details are not crucial, but what it showed is that for both blacks and South Asians, they actually had lower death rates than whites before COVID. after adjusting for age. And as I said, I didn't expect that because this was never been published anything on death rates before. This again is showing that for COVID, so these, I haven't got a pointer I'm afraid, but right at the top on the left you can see the black kind of dots with lines across them. It's basically showing that for COVID, death rates are higher for South Asians and blacks, whereas for non-COVID, they're lower. Whereas if you compare it to something like deprivation, you can see for both COVID and non-COVID, the more deprived you are, the higher the death rates. On the right-hand side, it breaks it down by certain diseases as well. So again, you can see for Asians, we'll focus on the top right there. For Asians, COVID-19, of course, higher death rates, whereas for cancer, dementia, when it mentions respiratory disease, it means non-infectious respiratory disease like chronic obstructive pulmonary disease. Has a lower death rate. The cardiovascular disease, that was, again, somewhat surprising, and it's not entirely in keeping with some other data I'm going to share with you. But the cancer and the dementia were significantly lower rates. This table, again, without going into all the numbers on there, but basically what it shows is that in 2020, which was obviously the worst year in terms of deaths from COVID, it shows that for every ethnic group, they had worse death rates compared to, apart from Chinese, they had significantly worse death rates compared to whites. If you look at deaths from other causes, they had significantly lower death rates compared to whites. And if you combine both together, for Bangladeshis and Pakistani men, they still had high death rates, and Black Caribbean men. And for women, there was no significantly increased risks. So that pattern was for the first data we've really got for 2020. We're waiting to see the pattern for 2021, and that will be published soon. Okay, now this is a very colourful slide with a lot of data on there. So just to explain, in green, so on the left you have all the different causes of death. In the middle we've got the different ethnic groups, and the colours, basically the green means you have a better outcome in terms of death, the red means a worse outcome, and amber means no difference, no significant difference, or no statistically significant difference. So focusing right at the top, all-cause mortality. This is data from 2012-2014, so obviously pre-pandemic, but it's the most recent data that we have. It's from the Office of National Statistics. It's the most reliable data we have. One of the challenges we face in this type of research is knowing the ethnicity of people. So if you go to hospital, it's meant to be recorded, but it's not always recorded. If you go to your GP, it's meant to be recorded, but it's not always recorded. It's not always recorded the same. So if you go to hospital, sometimes you'll be recorded as Pakistani, sometimes as Bangladeshi, sometimes as Asian. It's not always the same. I mean, you're meant to fill it in yourself, but in practice, that doesn't always happen. So what the Office of National Statistics did to get around that problem is they used the census data. So in the census, it's definitely self-defined, and there's no missing data because everyone has to fill in that box. So they used the census data to look at everyone that was in the census in 2011, and then they followed them forward for the next few years to see what people died of and what the rates of death were by different ethnic group. And so this is the best data we've got, the most reliable data we've got on death rates by ethnic group. So what it shows is that for all causes combined, that Indians, Pakistanis, Bangladeshis, Black African and Black Caribbean had lower death rates than whites. If you look at all cancers combined, which is the leading cause of death in the UK, a similar pattern. If you look at all what's called circulatory or heart diseases or cardiovascular diseases, or anything to do with the circulatory system, then Pakistanis and Bangladeshis have significantly higher death rates than whites. Black African, Black Caribbean again lower, and Indians slightly higher. So because cancer has become the predominant cause of death in the UK, and I'll show this in another slide, and that's changed over time, this might explain why now we're seeing this pattern of lower overall death rates in Pakistanis and Bangladeshis. I'm not going to go through every cause of death, obviously, otherwise we'll be here for a long time. And officially I've only got 7 minutes left. But just to focus on a couple of them there, you can see for dementia, I mentioned that earlier, so significantly lower rates of dementia and Alzheimer's disease amongst Pakistanis and Bangladeshis, significantly lower rates of chronic lower respiratory diseases, which is the main risk factor for which is smoking, and for lots of cancers. And for many cancers, tobacco and alcohol combined are significant risk factors. And of course, Muslims generally don't drink alcohol, and they're also less likely, especially amongst women, to smoke. So that explains a lot of the lower risks of cancers. And still we see a pattern which is linked to the countries of origin. So many of the cancers which are higher in South Asians, for example, reflect what's going on in the country of origin, like gallbladder cancer, for example. And some of the lower rates, again, reflect rates in the countries of origin. The other kind of quick 2 points is on the very right-hand side of this, you can see 2 columns there, which shows that if you're deprived in the UK, this is regardless of ethnicity now, you have worse outcomes on pretty much everything for every cause of death. There's no cause of death where you have a better outcome. And in the USA, if you compare blacks versus whites, it's a similar picture. Blacks generally do worse than whites for almost every outcome. So the pattern in the UK is quite different, for death at least. So you can see most of the table is either green or amber. This is life expectancy. So the Office of National Statistics also produced the first estimates ever for life expectancy. Again, it showed, as you'd expect based on what in the previous slide, that Pakistanis and Bangladeshis had higher life expectancy than whites. Indians had even higher, and Chinese, we're not done in this most recent thing, but Chinese also have higher life expectancy. So the only group that had similar life expectancy to whites, which is not shown on this slide, are the mixed group. But all the ethnic minorities had higher life expectancy than whites, whether in Scotland or England. And that data is very consistent now across a number of studies. And this is a summary of the results that I showed earlier as well. So just on the final point there, for the 30 leading causes of death, ethnic minorities had significantly lower mortality rates for about half, and higher for about a quarter. So what explains, I've mentioned here a paradox. So the paradox is that Pakistanis and Bangladeshis in particular are more deprived. So based on knowing that if you're deprived, you're less likely to you're more likely to die earlier, have a lower life expectancy. Why is it that Pakistani and Bangladeshis have a higher life expectancy? And black Africans to an extent as well. So that's why it's a paradox. And we've seen a similar paradox in America called the Hispanic paradox. No one's described it, as far as I know, in the UK as the Pakistani or Bangladeshi or Muslim paradox yet, but I suspect that's coming soon. In fact, in an article I wrote in the BMJ with some co-authors recently, we did describe this paradox, but it hasn't become widespread yet, but that might happen. The healthy migrant effect, so particularly for people that have migrated recently, obviously you only migrate, or you can only migrate if you have a certain level of health, particularly over the last, I would say, 40 years. So generally since the 1980s, it was quite difficult to move here from most countries unless you had a reason. So this kind of what was called a primary purpose, where you couldn't just move here for no reason. Whereas in the 50s, 60s and 70s, as the older members of the audience will know, as long as you were part of the British Empire, or had been part of the British Empire, you could move here. There was no restriction, so anybody could move here. So that healthy migrant effect wasn't as strong for Indians and Pakistanis and Bangladeshis moving in the earlier period. It's stronger for black Africans in particular, and Eastern Europeans moving in the later period. I think what's more relevant, as I said, is the relative change in death rates from cancer and cardiovascular disease or heart disease. So if you look at 30 years ago, heart disease, and this is on the right-hand side, and again, I apologize that not all of these graphs will be immediately apparent, but what it's basically showing is, if you look at the purple line at the top, cardiovascular disease used to be the leading cause of death in 1990 due to better treatments as well as reduction in risk factors like smoking and high blood pressure, etc. Death rates have fallen significantly from cardiovascular disease over the last 30 years. Whereas for cancer, which is the kind of turquoise type line, it hasn't really fallen. So now you can see that cancer is the leading cause of death. The right-hand side of that, where it's called years of life lost, this is more relevant to life expectancy. Of course, we will have to die eventually of something, but cancer tends to cause deaths at an earlier age than cardiovascular disease. And so because South Asians, Pakistanis, Bangladeshis have particularly better outcomes for cancer, that relative change in the cause of death from cardiovascular disease cancer is advantageous for South Asians, basically. And I think this is the main explanation as to why there's been this change over time. So if we had life expectancy figures in 1990, I suspect they would have shown that we had lower life expectancy than whites. We didn't have that data then. So we'll never know. But that's the most likely explanation in my view. What we do have data on is where people live, so life expectancy by area, and there is data for 1990, though I haven't shown it here, but the pattern is similar. So where we are today, Harrow, it's not, I didn't put Harrow just because I was coming here today, it was on there before as well. But Harrow, as you know, because you live here, is a relatively prosperous area, and so life expectancy has never been that low, even in 2001. So I should just explain. So the selection of places at the top there, these are all London boroughs, as you can see, with the highest proportion of non-whites in the country. So Newham is a minority, by far a small minority, which is white, and you can see there that most of the boroughs have a white minority, including Harrow. Harrow has a very high proportion of South Asians, and so the life expectancy data does reflect the ethnic composition to an extent. So you can see, we'll just focus on Harrow because I'm sure you're looking at that one, that for women, life expectancy was already high in 2001 and has got better, and for men as well. But what the purpose of this slide is actually to show particularly what's happened in places like Newham and Tower Hamlets. So Newham and Tower Hamlets, which again are heavily South Asian, used to have very much lower life expectancy, particularly for men. So in 2001, life expectancy there is roughly 73, lower than the national average, lower than the London average. Whereas by 2018 it had changed significantly, so it's now roughly the same as the London average and higher than the national average. So a very big change over 20 years, and again that's unexpected, because Tower Hamlets and Newham are still two of the most deprived, although there's been some gentrification and some improvement. If you look overall, they're still two of the most deprived boroughs in the country. If you look at the bottom half there, these are the places mainly in the north of the country where life expectancy, for example, used to be similar to Tower Hamlets or Newham back in 2001, but over the last 20 years it hasn't really improved, particularly for men. It's gone up slightly, but not as much as it has in these very ethnically diverse parts of London. There are parts of the north, as you'll know, where there are also significant ethnic minority populations like Blackburn and Bradford and other parts, and the data there is more difficult to interpret, which is why I haven't put it here. But they're somewhat intermediate between. So the lowest life expectancy is in the most deprived white areas. The highest life expectancy is in the least deprived, both white and ethnic minority areas. Places like Harrow, in fact, has one of the highest life expectancies, and the rest is somewhere in between. Okay, I'm almost done. I described the deprivation gradient earlier. So the deprivation gradient doesn't seem to apply as closely in Pakistanis and Bangladeshis. So if you look at the black group, for example, actually the white group I think is, if you look at the white group, it shows that gradient particularly for non-COVID causes. So if you're more deprived, I showed this earlier as well, if you're more deprived, you have a higher death rate. That doesn't seem to be as strong for Pakistan and Bangladesh. In fact, it doesn't seem to apply at all in Pakistan, and we don't have enough data to really explain why that is, but that work is ongoing. So the Office of National Statistics, they haven't published this data yet, but it will be published soon. But what it shows is that, again, in the UK, the group that does worst in terms of healthcare outcomes are deprived whites. Deprived Pakistanis and deprived Bangladeshis do significantly better than whites. And the groups that do best are non-deprived whites, Indians, and Chinese. I think this is my last slide. So I've got there race, religion, place, and poverty. So just in summary, the key drivers of poor health outcomes in the UK remain kind of where you live and how poor you are across all ethnic groups. There is a gradient there. But the relationship is different in South Asian groups. And what I would just conclude with is to say that ethnicity and health outcomes by ethnic group or religion is complicated. There's different diseases, the disparities go in different directions. Each disease has its own risk factors, and it's not as simple as to generalize across everything. So we need to do a lot more work to understand what's driving these disparities and inequalities. But we should, I think, be pleased, that for many diseases we're doing better. And there's aspects of our lifestyle which are driving that. So not smoking, not drinking, multi-generational household, etc., are responsible for some of those better outcomes. And so I think the wider community can learn from us and from the British Muslim community as to how to improve their health. So thank you for your attention. I was very impressed by the kids, actually. You've done better than some of my students at university. So,
okay, we have time for some questions. Are there any questions from the side?
Thank you. It was not as complicated as you think. It was quite interesting, and I think I got most of it. But anyway, my question is this. It seems that cancer is taking over. So has research been done as to why, other than drinking and smoking, colon cancer, is it related to diet? There's some other, do you have any?
Yeah, no, that's a good question. I didn't go into in detail. So tobacco, alcohol, and obesity is the other key risk factor for many cancers, and obesity levels have increased over the last 30 years as well, and that's partly driving it. For women, breast cancer is still the leading cause of death from cancer, and or the leading cause of incidence for cancer. Lung cancer actually causes more deaths, but for breast cancer, one of the biggest risk factors is the number of children you have, and birth rates have gone down, and again, that's one of the reasons for increasing incidence of breast cancer. The more children you have, the less chance of breast cancer. Yeah, and that's why Bangladeshis have the lowest rates of breast cancer. They have the highest numbers of children as well in the UK.
And any other questions?
Thank you very much, Raghib. Just a few specific points.
Sure.
So with the mortality in black people during COVID, you said they're pretty much genetically immune to dying or something similar, right? They have very low incidence of the gene that...
I was saying they haven't got the gene that makes the outcome worse once infected.
Yeah.
And their higher risk of death was mainly because of high risk of infection.
Okay. And then what happened in the second wave? Why did they suddenly plummet to the lowest risk of death?
So that was because they had a lower risk of infection.
Why suddenly?
So in the first wave, I mean, we don't know for certain,
yeah.
So this is partly speculation, but I think it's consistent with the higher proportion of black African and black Caribbeans who work in healthcare. In the first wave, infection rates in healthcare workers were very high. Lots of people, particularly in February and early March, were not wearing PPE at all because it wasn't mandated at that time. Many people got infected. They took the infection to their households. To elderly relatives. To me, that seems the most likely explanation for that. And then by the second wave, everyone was wearing PPE in hospitals, in social care as well. Social care is the other area where black people are overrepresented. So I think that's the most. It doesn't explain everything, but it's I think what we have some evidence for.
So why did we not see the same change in Pakistani Bangladeshi communities in the second wave? So
the Bangladeshi and Pakistani, maybe I didn't explain it well enough, but in the second wave it was mainly driven by higher rates of infection in over 60s in particular, and the link to having children at home for that age group was much stronger in the second wave than the first wave. In the first wave, when schools were closed, there wasn't as much infection. In the second wave, when they're open, there was more infection, and that was driving it.
Okay, but why would there be a differential between ethnic groups? Do black people have less children living at home? A lot less?
Yes, they do have a lot less. So maybe, again, I can hopefully maybe just show that slide again. So it's not that common, actually. Let me find it. So it's 56%, I think, for Bangladeshis, 35% for Pakistanis, whereas for black Caribbean, it was only 6%, black African, 11%.
And then you said in the third wave, we had a lower risk of infection. Is that correct?
Correct.
Asian communities had despite lower rates of vaccination. How does that?
So that is most likely due to natural infection. So in the first two waves, so now we know, and we've got data, as you know, from the antibody studies that show the proportion of people that have got immunity through vaccination versus natural infection. So in the first two waves, because our rates of infection were so much higher, in Pakistan and Bangladesh, a higher proportion were immune basically through natural infection. So the combination of vaccination and natural infection overall was likely to be higher than it was in. So in fact, all of the patterns were reversed. So in the third wave, the least deprived areas, the least deprived had the highest infection rates, the least densely populated had the highest rates. All the previous things were reversed, which again fits with that their immunity levels were not quite as high. And the vaccines, as you know, don't provide 100% protection against infection. They have much better protection against hospitalization and death.
So this data suggests that having had COVID provides you with better immunity
There
than taking vaccine. Am I
No,
hearing that correctly?
Not quite. So what we have got better data for, so natural infection versus vaccination, there's conflicting data actually. So there's some evidence that suggests that you do get better protection from natural infection, and there's other evidence that suggests the opposite. What there is much better evidence is that the hybrid immunity, so which actually most of us have now, so having had both vaccination and natural infection provides the best protection. So something like 70% of us now have hybrid immunity, and that proportion is not broken down by ethnic group, but I suspect that's what's happened in the third wave.
And then the other thing that I find quite muddling about all this sort of infectious versus non-infectious disease is the play of risk factors. Can you tell us whether obesity is higher in South Asian communities than in white communities, whether other risk factors such as hypertension, diabetes are higher or lower, or what's going on with those? And
no, it's a good question. I didn't present all the data. So diabetes is definitely much higher amongst South Asian communities. We have the highest rates of diabetes. Hypertension is definitely much higher amongst black communities and somewhat higher in South Asian communities. Obesity is mixed. So if you look at younger age groups, we're starting to see higher levels of obesity, particularly amongst blacks compared to whites, and to an extent in Pakistanis as well. But in the older age groups, obesity is still, if you take South Asians as a whole, it's less common than amongst whites. We don't have very good breakdowns one of the challenges we've had with ethnicity, as you know, is if you take South Asians as a whole, it hides a lot of heterogeneity between those or within those communities. So I haven't seen good data on obesity levels by Pakistanis, Bangladeshis, Indians at older age levels. Not recently. The last data we have, I think, was from 2004.
it seems the data that show that those risk factors are likely to cause you to die for COVID, and we thought were likely to cause you to die for non-COVID diseases do not. I mean, the relationship between risk factors and death seems to have broken down here in these communities.
I mean, obesity, you're right, is a risk factor for non-infectious diseases, but I don't think it's broken down. I think it's, as I described, the majority of excess risk for Pakistani and Bangladeshi is risk of infection, and I think we've got good explanations as to why that is. The residual risk is mainly this genetic risk factor, which again wouldn't apply to the non-COVID deaths. So the relationships might be different, but I don't think they're in opposite directions. I mean, as I said, it's a lot of this is driven by cancer and individual cancers. So South Asian women, Pakistani and Bangladeshi women are very unlikely to smoke, or they have much less lower levels. So that's, the biggest cause of cancer immediately is much lower. Breast cancer, again, I said, is much lower in South Asians. Colorectal cancer, there might be a dietary factor. I mean, one of my areas of research has been in South Asian and colorectal cancer. So the spices that we eat, this is again speculation, but no harm in a bit of speculation. The spices that we eat, there's some evidence that they have an anti-inflammatory impact, a bit like aspirin, which is known to reduce the risk of colorectal cancer. And so for the three kind of key cancers, we have explanations for lower risk. Prostate cancer, I don't think anyone has a good explanation, but we have much lower risk of prostate cancer as well, probably mainly driven by genetics.
Great. There's been there are a few questions. One from online. Has there been any research on vitamin D or lack of vitamin D in ethnic minorities, which could have been responsible for many deaths or not?
So there's been a lot of papers published on vitamin D and COVID, and they're not all consistent. But the best evidence we have, without going into the details of how we do these kind of studies, suggests that it's not a major cause of the differences. If those who are interested can look it up, they're called Mendelian randomization studies, which provide better evidence, and they suggest that there's no relationship between vitamin D levels and outcomes from COVID. But there is conflicting data, and in general I would advise all people with darker skin to take vitamin D during the winter.
Okay, thank you very much. I was looking at Professor Marmot's study on deprivation especially, right? Now, from what I gather from your data is that if you are deprived, then it's much worse to be white than non-white, because the outcomes are much worse.
Yes.
But has there any work been done? Why do a number of communities become deprived in the first place?
Yeah, I mean, that's in some ways a non-medical question, but you're right. The social determinants of health, which Michael Marmot really pioneered, explain most of the difference in death rates, much more so than access to healthcare. Some of this is quite historic. In fact, I saw a paper recently saying a lot of it goes back to William the Conqueror. And the harrying of the North. So the northern communities have done worse for a long time. Of course, it's not that we couldn't reverse that over the last 1,000 years, but governments of both kind of flavors over the last 50 or 60 years have not been able to really reverse these significant gaps in life expectancy between poorer and richer areas, between the north and the south. But they're mainly socioeconomic, so higher levels of unemployment, higher levels of kind of single-parent households, higher levels of smoking, alcohol, drugs, dependency, etc. All of those things are much more common in poorer areas. And that's not just a UK phenomenon, that's something which is seen across the world.
For the Pakistani and Bangladeshi communities, as you rightly said, they're probably concentrated in 5 big conurbations, right?
Yes.
With the biggest one in London and around London. So that deprivation probably is due to racial discrimination.
I mean, immigrants, by their nature, don't have property when they come. I mean, like my father, when he arrived here, he came with, as I'm sure most of the older generation, without anything. They came with whatever, well, with nothing usually, maybe £5 or £10, and then they studied, they worked, and over time they built up. Thank you. They built up wealth, and now the Indian community, for example, has higher wealth on average than the white community. But it's taken, 3 generations. More recent immigrants, of course, that takes a longer period of time. But the trends for many things are encouraging. So education, as it was for many of us, for myself, for example, coming from a poor family, but getting a good education took me from being on free school meals, which is the most deprived group, to now, alhamdulillah, where I am today. And that's not uncommon. There's many people from Pakistani and Bangladeshi backgrounds and Indian backgrounds that have had that similar journey. And now, again, we're seeing that trend over time. People from those communities often own property in their countries of origin, which of course is not worth as much in pound terms, but has value in their countries of origin. So I think it's quite difficult to measure some of these things. The other thing, as I said, the main measure of deprivation is based on postcode. And if you go to certain postcodes which have historically been poor overall, but if you look at individual kind of wealth people who are living there, then it's not that, and there's some evidence of this. I can't show you the papers, but there's some evidence that there's a bigger gap between individual wealth in kind of Pakistani, Indian and Bangladeshi areas. Even though the postcode is poor, the individual living there. So what tends to happen in some areas is when you get wealth, you move out to a better area. So my in-laws, for example, are from Ilford, and as they've got better off, they could have moved out, but they've decided to stay for kind of extended family reasons, and that's not uncommon. Even in places like Bradford, or it's quite common to stay, but to improve your house, even though you've become better off. So I think it's quite difficult to make exact comparisons based on postcode, but we need more work on that. But as I said, I think the trends are generally going in the right direction.
Okay, we've got about 4 questions left. Let's start with the one. What would we have done differently if we knew about the infectious disease differential in advance?
I mean, there's lots of things I think we would have done differently, particularly in relation to occupational risk. We could have ensured that people had better, I mean, maybe it was too late by the time we knew, but access to PPE, not just in hospitals, but taxi drivers, security guards, etc. Multi-donor households is a much more difficult one to manage. To suggest that people who are older should stay separately is not really practical for most families, and is not helpful either, because there's lots of disadvantages for them living separately from their children and grandchildren. And it would have been for quite a long period of time. I mean, we've been living with COVID now for 2 years. So at some point they would have, I don't know what the solution is there, other than what we tried to do once we had vaccination, which was to encourage people living with parents and grandparents to get vaccinated. And one thing I was happy I was able to persuade the government was to allow kind of multi-generational households to be vaccinated, even if the age groups were lower, and to add people from ethnic minorities to the clinically kind of vulnerable list. So you may remember, I think maybe in March last year, it was significantly expanded, the clinically vulnerable list, and ethnicity was taken into account in that, and that allowed them to get access to vaccination earlier. But there's lots we could have made. In hindsight, of course, there's lots you can do. Yeah.
Thank you, Raghib, for the presentation. Just one or two questions. First of all, with regards to cancer epidemiology, have you seen a decay effect over time in the association between migrant groups in the UK and the types of cancers that develop, and the strength of that relationship with cancers in countries of origin?
You want me to answer that first? Okay, so we have hardly any deaths from cancer in second and third generations. So the comparisons that have been done have been based on so nearly all deaths from cancer, this is deaths now, nearly all deaths from cancer have been on people who migrated. So what we tend to see, and this has been shown, for example, with Japanese that moved to America, to Hawaii, is that over time, the risks kind of moves towards the host or indigenous population. And so, for example, with Japanese that moved to Hawaii, their risk of colorectal cancer within one generation in their case was the same as white Hawaiians. So we haven't seen that in the UK. So the risk of colorectal cancer is still lower amongst South Asians, which again may go back to the point I was earlier, about diet. Maybe that's protective. But we don't know in the UK yet. It's likely that our rates of that ethnic minority rates of cancer will approximate closer to the white majority over time. That's what we've seen in other places.
The other question I had, now that you've mentioned the sickening of the ethnic body as it resides within the UK, is about heterogeneity here. You touched on heterogeneity amongst subcontinental ethnic minority populations, but how does that relate to this postulate about genetic predisposition?
I mean, India on its own is not really one country. It's more like 20 or 30 countries. If it was in Europe, it would be 20 or 30 countries because of the different languages. So it's quite difficult to generalize even within the Indian group. Bangladeshis maybe are slightly more homogenous, and Pakistanis again are quite heterogeneous groups. We don't have good data for within Indian communities within Pakistani. What we do have, and I presented some of it, I think maybe I'm not sure whether you saw the data, but for Pakistanis, Bangladeshis and Indians, we can see those differences for certain outcomes. Although for COVID, it seems that the excess or the increased genetic risk may be slightly higher in Bangladeshis. So if you look at the carriage rates of that mutation, it's higher in Bangladesh than Pakistan, for example, based on that data. So there may be some slight differences there. For other diseases, to be honest, I don't think we have enough information. I mean, there's a new study starting soon called Our Future Health Study, which is hopefully going to answer some of these questions because it plans to recruit a much bigger number of people from ethnic minority backgrounds to finally look at this in detail. Sure.
And then finally, just tying in social determinants with COVID outcome, how free are ethnic minority groups to choose where they live? Because you mentioned that where you live is a significant determinant of your mortality and severity of disease. And historically in the UK, we've been subject to redlining as in the US, difficulties of access to credit, tight association with particular forms of employment. So all of these restricting mobility. How does that play into this?
I mean, I don't know the answer. It's not my area, to be honest. But what I would say is that living in London, for example, was bad for COVID death rates, but it's good for non-COVID death rates. And London now has the highest life expectancy of the various regions, and a big change over the last 30. So it's not that living in London is bad for your health in general. For infectious diseases, it's got particular because it's a densely populated area. But as we know, for educational outcomes, for wealth, and now for health, London actually is doing much better. So I don't know whether people were forced to live in London or not, but it actually hasn't been bad in general. I mean, COVID is really the exception. For places like Birmingham, Bradford, Blackburn, it's slightly different. And I don't know, I haven't looked at it in detail enough. But even in those places, if you look, for example, at the overall life expectancy in more ethnic minority areas compared to white areas, within those northern towns or cities, again, the whites seem to do somewhat worse. So yeah, but that doesn't answer your question, because I don't know the answer to your question, to be honest.
Salam. Thank you so much for your presentation. In an attempt to try and analyze or understand the low uptake of vaccination within the Pakistani group, is there a difference between the two genders within that community? Is there a difference between various age groups within that ethnic group? And as a general practitioner, I have noticed anecdotally that the younger members of the family are more reluctant, and depending upon how influential they are on their parents or the elderly, they could actually deprive them of the vaccination as well. It's intriguing, and I keep on thinking about what are the factors that's making them stay away from vaccination. Is it general worldview? Is it trust? Is it a political party that you belong to? Is it the exposure to the imam of the local mosque? I mean, what are your views about this?
I mean, there has been some work done. I mean, in answer to your first question, so there's definitely a gradient. So the younger you are, the less likely you are to take the vaccine. It's even lower in women of childbearing age, because there was concerns initially about the vaccine, although that's now well disproven. There's no impact of the vaccine on either fertility or on children. But they, once misinformation is out there, it's quite difficult to overcome it. For Pakistan, so Pakistanis have significantly lower rates than Bangladeshis, and I don't think there's been enough work done to fully explain that. But one of the possible reasons, as you may know, in Pakistan, for example, when they were trying to find bin Laden, that was somewhat involved, I think, with the hepatitis C or B vaccination program, and that led to distrust with vaccination in general. And some of these things were also seen in African countries, and of course for blacks in America, there's a very bad history of how they've been exploited for medical kind of experiments. So that distrust is partly historical, it's partly based on their interactions maybe with health systems here as well, or distrust of government. And so trust has been a key issue, and it hasn't been as big an issue with other health outcomes, but for COVID and with vaccination, it's really had a big impact on uptake rates. But yeah, there's still more work to be done on that.
Last question.
So, what would you do if you were COVID?
What would I do if I was COVID? So I'll answer the question that I was asked at the school. So what would I say to someone if COVID was a person? And the answer I gave is that I would say, at that time I would say stop mutating, but I would change it, so I'd say, don't change anything about yourself. You're fine as you are. So the current variant of COVID that we have, we can handle, and we don't want it to mutate further, because I mean, as a serious point, I mean, the vaccinations, as I said, and I want to make sure this is not misunderstood, they do provide very good protection against hospitalization and death, not so good against infection. And even if anyone listening hasn't taken their first dose, I would strongly encourage them to do so. If they haven't taken their second or third dose, I would strongly encourage them to do so. We've got overwhelming evidence now that it very much reduces your risk of being admitted in hospital and death.
Thank you very much. If there are other questions, we can ask them afterwards, but we have run out of time. Thank you very, very much for speaking. Salat ala Muhammad wa ala Muhammad. Just a reminder, next week, on Thursday, we have the A'mal program for the 15th of Sha'ban, starting at 8 o'clock. And next Friday, we have Sheikh Arif, who will be speaking to us, celebrating the 15th Sha'ban as well. So if you'd like to find out more, go to SICM.org.uk. Salat ala Muhammad wa ala Muhammad.